When you have your patient in the ward, emergency or the ICU and you need to initiate the IV fluid to the patient, you think which one will be best for patient? Will it be normal saline? Should I go with ringer lactate? Or you think, yes, your senior might have started DNS to some other patient. So should I go with DNS or maybe 5% dextrose? Or albumin is best for the patient? So these questions, they keep on coming into your head. And it feels very lame to ask your senior or to consultant which IV fluids to start with. And that is why you need to know everything about the IV fluid, when to give, how to give, and obviously when not to give. That is more important. In this video, I'll cover everything which you need to know for your clinical practice. So let's get started. Now, before diving into the IV fluids, the type of IV fluids, when to give it, we need to know just the basic of our physiology of the body fluid composition. In this diagram, you can see we have the plasma, which is the intravascular compartment. Also outside that, but we have the cells and the interstitium. So inside the cell, the water which is present is obviously called as intracellular compartment or the water, right? Whereas the water which is present or the fluid which is present in the interstitium plus in the plasma is considered as extracellular because it is outside the cell. So 2/3 is contributed by intracellular and 1/3 is contributed by the extracellular. And further, if you talk about extracellular, 1/4 is contributed to the intravascular compartment. So this is just a basic physiology of our body fluids. Now, which one, right? So how do we see these IV fluids and how are they categorized? First of all, it is categorized into two main. One is crystalloid, second is colloids. Some book they also mention as the blood or the blood products as the third one. But I feel IV fluids are only two, crystalloids or the colloids. Now, these crystalloids, they are just a water with electrolyte or sugar in it, right? Whereas colloids have larger molecule, have proteins in it. Whereas if I talk about the crystalloid, they have small molecules which can cross the semi-permeable membrane, or you can say they can cross the vessels and can go into the interstitium and further into the cell. Whereas the colloids, they remain in the intravascular compartment. Now, if I talk about the crystalloids, they are further divided into three, depending on the tonicity. One, isotonic, second, hypotonic, and third, hypertonic. In isotonic, what do you mean by isotonic? That means the relative tonicity in comparison to our plasma is similar. Right? So if you give isotonic fluids to some patient or to these patients, obviously that is much better because the tonicity is almost similar to as of our plasma. And the example for isotonic fluids are, one is 0.9% NaCl. I have not mentioned as normal saline because it is not normal. I'll talk about in the later part. So it is 0.9% NaCl, which is also called as normal saline, but it is a misnomer actually. Now, second isotonic fluid is ringer lactate. And third is Plasmalyte. So these are the three, somewhat we call it as isotonic fluids. Now, if we talk about the hypotonic, one, it is 5% dextrose. Second is 0.45% NaCl. Or it can be 0.225 NaCl. Third are the category which we call as hypertonic. They have more tonicity as compared to our plasma, in which we have 3% NaCl, we have mannitol, and then we have 10% dextrose as well as 25% dextrose. So this is how we categorize crystalloids, and they are the small molecules. Now, if we go on to the other side, talking about the colloids, they are subdivided into either they are naturally derived or they are synthetically prepared. The example for natural colloid is albumin, which comes in the percentage as 5% or 20%. Whereas the other side, if we talk about the synthetic preparations, which we have are the gelatins. The other one is HES or the starch, and third are the dextrans. So this is the full classification or the total amount of IV fluids which we have available in the market. And then again the confusion comes, which one to go with, whether it is NS, D5, 10% dextrose, albumin, which one to go with. Now I'll discuss each and every fluid one by one, and obviously I'll be talking what is required for your clinical management. Now the first fluid to talk about is 0.9% NaCl, which is also called as normal saline. And let me tell you, it is not normal, right? Why? Because the osmolarity is somewhat higher than the plasma. Now, if I talk about the concentration present in this NaCl is sodium having 154 milliequivalents per liter and chloride also 154 milliequivalents per liter. Now, if you club these two, the osmolarity or the solute which is being present in the solution is 308 milliosmol per liter. This is the osmolarity of NaCl, right? And that is why it is not normal. Because of our plasma, it is 280 to 290, or you can say 285 to 295 milliosmoles per liter. This is the normal one. And for NaCl, it is 308. Now, if I talk about, obviously you can give with the IV fluid, the IV cannulas, there, right? For the 0.9% NaCl, you do not need any central line. Now, talking about the indications of it. First of all, you can give for the resuscitation, right? As in cases of hypovolemia. Let's say patient comes to you with vomiting, with diarrhea, with excessive diuresis, or maybe initial stages when patient has come to you with bleeding, acute bleeding. In all these situations, you will go with normal saline or 0.9% NaCl. Secondly, in the cases of DKA, diabetic ketoacidosis, you will prefer this one. Third, I would say it is hypochloremic metabolic alkalosis. You will go with normal saline. Next, it could be in the cases of hyponatremia. Or you can even go with in the cases of hypercalcemia. Whenever there is more of osmolarity in the body or a hyperviscosity state, you go with resuscitation or giving hydration with 0.9% NaCl. And lastly, I would say you can use this normal saline to dilute many drugs, right? So then you can even, this is used as a vehicle for many drugs or the medicines. Now, if I talk about the contraindication when not to give, again, this is much more important than to know the indications, right? We all know the indications. But in the situations when we have hyperchloremic metabolic acidosis, and this usually happens when you keep on giving more of 0.9% NaCl, right? Because of high chloride, 154 milliequivalents is very high, right? Because of the high chloride content, what we get is hyperchloremic metabolic acidosis. So this is, first of all, a side effect also, but if it all present in the body, then you should not give 0.9% NaCl. And secondly, in the cases when you have the heart failure or CCF, congestive cardiac failure, or maybe when you have the renal failure, in these situations, you should not give normal saline. Now, the second type of IV fluid is ringer lactate, in which we have sodium in a concentration of 131 milliequivalents per liter, chloride in a concentration of 111 milliequivalents per liter. Also, what we have in ringer lactate is potassium, which is 4 milliequivalents per liter. Calcium is also present in a concentration of 2 milliequivalents per liter. And lastly, what we have in ringer lactate, as the name says, is lactate, which is 28 milliequivalents per liter. Now with this lactate, this is converted to bicarbonate in the body, and that too at the level of liver. So if liver is functioning well, then yes, lactate is being converted to bicarbonate, and hence it can be used in the cases where we have metabolic acidosis. And typically we have this situation when we have a lot of diarrhea, right? So diarrhea induced hyperkalemic metabolic acidosis is the place where RL should be preferred. So if we talk about the indication, this is the first one. In fact, this is the fluid of choice in the pediatrics where you have dehydration induced by the diarrhea. It should be given. And also we use ringer lactate for the resuscitation also whenever the patient is in hypovolemia, as we discussed with 0.9% normal saline. And next is just as a maintenance fluid, just like that of normal saline. Now we need to know when not to give ringer lactate. First of all, in the case of liver failure or whenever liver functions are not good. Because what happens is lactate will not be converted to bicarbonate and hence it keeps on increasing, causing more of lactic acidosis and then can be deleterious. So one most important contraindication remains liver failure. Second, if you have to give blood along with ringer lactate, then it should not be given. Why? Because what you have is the calcium. Calcium chelates with citrate and hence gets precipitated. It should not be given. Third, in the cases of when you have hyperkalemia already, although the potassium in the IV in this ringer lactate is not much, it is just 4 milliequivalents per liter. But if the potassium is in rising trend, right, patient is not passing urine, you should not prefer. Now coming on to the next one, which is the Plasmalyte, which comes under isotonic crystalloid. And this is, as the name says, Plasmalyte, it is just similar to that of our plasma. Having a sodium concentration of 140 milliequivalents per liter, similar to our plasma. We have the chloride as a concentration of 98 milliequivalents per liter. Also what we have is a potassium, 5 milliequivalents per liter. And in place of calcium in this solution, what we have is the magnesium, 3 milliequivalents per liter. Also, in ringer lactate, we have lactate. Over here, what we have is the acetate. Almost similar concentration, 28 to 29 milliequivalents per liter. And the pH is in the range. It is in the range. Now, the osmolarity of Plasmalyte is very similar to our plasma, which is 290 to 295 milliequivalents per liter, milliosmoles per liter. So again, just similar to our plasma. So that is why it is called as BSS, balanced salt solution. And this is the most balanced solution ever available, right? And for sure, when this is so much balanced, you need to prefer it for the resuscitation as well as for the maintenance therapy. But again, you need to consider, because it has potassium in it, you should not give when it keeps on increasing as in a hyperkalemic states, right? Otherwise, yes, you should prefer. Even for the sepsis nowadays, they say Plasmalytes are the best solution to start with. Not the normal saline, not the ringer lactate. It is the Plasmalyte now, right? It is in the guidelines as well. Now, going forward to the next IV fluid, which is a hypotonic fluid. The first one in hypotonic, which we'll talk about, is 5% dextrose. And we all have used it, right? The 5% dextrose. Now, what do you mean by this 5%? This means 5 gram of dextrose is present in 100 ml. Or in the other words, it is 50 grams of dextrose in 1 liter. Now, this 50 grams give approximate 170 kilocalories, because 1 gram gives around 3.14 kilocalories. So if you multiply 50 into 3, comes out to be 150, and somewhat more than that, it is actually around 170 kilocalories. This is from the 50 grams, right, in 1 liter, from full 1 liter. And what we keep on giving is the 500 ml bottle. Right, so you have to give 2 bottles, 500, and then it provides just only 170. So do not just think that if you are giving 5% dextrose to the patient, 1 liter, and this is sufficient for the energy requirement. No, it is not. It is not, right? So please, either you give around 2 to 3 liters to the patient, or give some supplemental nutrition, right? If we talk about if it is allowed to the patient. But as in case when the patient is kept NPO or nil per oral, Then what we give is the dextrose or dextrose containing fluid so as to meet the basic requirements of the cells. Right? So indication remains whenever you are not able to give, as in case of post-surgery or even for the pre-surgery. Right? Then we prefer, or in the cases of hypoglycemia. And now if I talk about the contraindication when not to give 5% dextrose, first of all, very, very, very important is the cerebral edema. Now why? What is the reason behind? Now this 5% dextrose, when you give it into the intravascular, it diffuses out to the, from the vessel into the interstitium and is metabolized and converted into the free water, which very rapidly goes into the cell, causing cellular swelling. So in the cases of cerebral edema, already the cells are swollen. If you give 5%, it increases that cerebral edema, right? So in acute neurological states, let's say patient has hematoma or a bleed, there is a stroke, you should not prefer, or let's say a post-op case, neuro case, you should not prefer 5% dextrose. Also, the osmolarity of 5% dextrose is on a lower side. It is just 252 milliosmoles per liter. So it is hypoosmolar, right? So it is not to be considered in a neurological acute neurological insult or the cases. Secondly, obviously we all know in a diabetic patient or whenever you are having hyperglycemia, it should not be considered. Now, moving further to our fifth one is, which also comes under hypotonic solution or the crystalloids, which is 0.45% normal saline. Again, it is just half of it, right? And we prefer these hypotonic solutions in the cases of hypernatremia, right? So as to manage hypernatremia. So these both can be used, either the 5% dextrose or maybe the 0.45% normal saline. Going further to the hypertonic solution, what we have is 3% normal saline. In 3%, the concentration of sodium is 513 milliequivalents per liter. Similar is of chloride, 513 milliequivalents per liter. So hence, the osmolarity, if we add these, comes out to be 1026 milliosmoles per liter, which is very, very high as compared to our plasma. It is almost more than 3 times of our plasma, right? And whenever a fluid have the osmolarity more than 3 times the plasma, you should give these kind of fluids from the central line. It can be internal jugular, it can be subclavian, it can be femoral, but it should be ideally be given from central line. The reason behind that is if you give from the peripheral line, it can cause thrombophlebitis, very intense one, right? So it should not be given. Only given through a central venous route. And if I talk about the indications of 3% saline, it remains first of all hyponatremia, and second in the cases of increased intracranial pressure, right? So whenever the pressure is raised, then you prefer giving 3% saline. And the contraindication remains whenever there is congestive heart failure or the congestive cardiac failure. Now moving further, the next agent is mannitol in hypertonic crystalloids. So that also have more of diuresis, osmotic diuresis, right? And it has more of hyperosmolar solution. And again, to be given from the central venous catheters. And this is also preferred in your increased intracranial pressures. Right, so as to decrease that pressure, and that pressure is being decreased because you are giving hyperosmolar solution. These hyperosmolar solution, they extract water from the cerebral cells and ultimately causing shrinkage, right? Because in acute stages, what you develop, let's say acute hemorrhage, acute bleed, acute trauma, what you develop is cellular swelling, the cerebral cellular swelling. And with that swelling, you have to remove those extra fluid from the cell. And then what we use are these kind of hypertonic solutions, right? And if I talk about the contraindication when not to use mannitol, very important is renal impairment. Whenever your kidney functions are not good, you should stop or you should not give mannitol. And second is when your serum osmolarity is more than 320 milliosmoles per liter. These are the two contraindications. The other hyperosmolar remains 10% dextrose and 25% dextrose. Obviously, we prefer these solutions in the case when patient has hypoglycemic episodes. Right, so we go with even 25% or maybe 50% depending on the severity, and we prefer 25 or 50% when we have to give less of fluid to the patient and we need to improve the the sugar of the patient or the glucose of the patient. Now, this is about the crystalloids. Now, talking about the other IV fluids which we have are the colloids, and we discussed earlier it can be natural or it can be synthetic. And the first we'll discuss is albumin, very important. And this is the only which is nowadays used. We should not use the other ones, although I'll just talk briefly about them as well. Now, albumin comes in 5% or 20%, right? Sometimes it is also 25%, but usually it is the 5 and 20%. Now, this albumin, it stays more longer in the intravascular compartment. Right? It doesn't diffuse out because of the macromolecules or because of the proteinaceous content it has. Now, because it stays in that, this is for the 5%. But if you give 20%, this attracts and pulls water from the interstitium, and hence these increase the intravascular volume, and that is why these are also referred as volume expanders. Now, there are only certain indications where you need to use albumin. The first, whenever there are hypoalbuminemia, the albumin is low, yes, you have to give. Second is HRS, which is hepatorenal syndrome. Third, when you go with large volume paracentesis, usually more than 5 liters. What you have is SBP, spontaneous bacterial peritonitis, and in cases of plasmapheresis. These are actually the indications of albumin. You should not, otherwise, if not indicated, you should not, right? People, what they do is, in the case of hypovolemia and if in the cases of hypertension, they prefer giving albumin, but it doesn't stay much in the intravascular compartment. It is not much useful, right? Because the problem or the side effect is very high. And the side effect can be anaphylaxis, pruritus and anaphylaxis, very important. Also, it can cause coagulation problem as well. Now, if I talk about the other synthetic colloids, which are gelatin, HES or the starch, and third are the Dextran. Gelatin is derived from bovine collagen. And because of that, but the problem with the gelatins is you can have anaphylaxis. But the best part is you can give larger volume of the gelatin, right? There is no renal impairment. There is no dose modification for the renal impairment. And the other one is there is no problem with the coagulation. Whereas if I talk about the other two, which is HES, the hetastarch or the pentastarch, all the starches, or even the dextrans, they have the problem with the coagulation. Right, so you should not prefer whenever there is already a bleeding tendency and all these things going on. You should not keep on giving. There is a set range, set volume to be given, to be delivered. Right, so this is all about, and nowadays we don't prefer all these, the synthetic preparation of colloid. What we prefer is just the albumin, right? Although some of the centers, some of the hospital, they keep on giving gelatins or the dextrans or HES. In fact, I also used to give previously, but now as the guideline says, no, you should not use it. Right? Until unless you're not able to get that blood or the blood products, and the patient is going hypertensive, there is nothing in your hand, then yes, because it is cheap and easily available as compared to the albumin, yes, you can go ahead with gelatins, right, or HES. So this is all about the IV fluid, which I feel is important from clinical point of view, which will help you, which should help you in your clinical management. Right? And I feel now after whole session, there is no need to call your consultant or your senior which IV fluid to start with. I hope this was useful, and kindly leave comments in the comment section if you found this video helpful. Okay, bye-bye. Take care.